Hello, everyone, and happy Thursday. I'm Janet Walker, a professor at Portland State University here in Portland, Oregon, and co-director together with Eric Bruns of the National Wraparound Initiative. On behalf of the NWI and the Wraparound Evaluation and Research team at the University of Washington, I welcome all of you to our webinar for today. I'm guessing that everyone out there has experienced having professional meetings or events canceled due to risks associated with the coronavirus. I'm also guessing that pretty much everyone has also experienced having some of these events moved online, giving us plenty of opportunities to wonder about important questions like, how is it that everyone else's haircut seems to be holding up better after 10 weeks than mine? And what's up with my webcam making me look like that? Anyway, for those of us on today's webinar, the annual conference on child, adolescent, and young adult behavioral health held in Tampa was something that we planned on like clockwork every March for the past 33 years. This year, we had made all our preparations and were getting ready for travel when the conference was canceled in early March. But the silver lining to the situation is that today we have the opportunity to share with all of you, a much larger audience than we would have had in person, findings from some of the most recent research on wraparound. So in the next hour or so, we'll hear about the latest meta-analysis of outcomes from wraparound, a study of Medicaid cost savings from Connecticut, a quasi-experimental study of CAN's outcomes for wraparound versus alternative services, and relationships between provider organization conditions and wraparound fidelity and outcomes. The presenters will introduce themselves at the start of their respective sections. And just a reminder that all of the members of the audience will be on mute throughout. We strongly encourage you to use the chat box to submit questions, which we will take at the end. We've saved plenty of time. Everyone will also receive information about the webinar recording and the slides once they have been posted. And with that, I'm going to turn it over to Jonathan Olson for the first presentation.
All right, I am having trouble getting to the slideshow mode on my slides. I'm wondering if Nick, our administrator, could help me with that. Okay, I'm going to give it a moment. I'm going to close this and open it back up and see if that will help us. There we go. All right. Even though we practiced it earlier, still have technical problems. Okay. First, our first slides, I'm actually going to hand it over to Eric Bruns, who's going to get us started on this presentation, and I'm going to jump in and talk about the methods and our results and take us from there. So Eric, if you can join audio and take us through the first few slides.
Absolutely. So can everybody hear me and see me? I think that's true. If not, let me know. So good afternoon, probably for most of you. Good morning for those of you here on the West Coast with us in Seattle, Washington. I'm very pleased to be part of one of four teams that are going to be presenting some of the presentations from the this year's canceled Tampa Research Conference on Children's Mental Health. All of these presentations are focused on wraparound care coordination and measuring different aspects of outcomes, costs, implementation, and measurement options. And I'm really thrilled to be able to kick it off with something that I know a lot of folks have been paying attention to over the years, which is summaries of the outcomes research base for wraparound. If you could go to the next slide, John, that would be fantastic. And just to note that this is a team effort among us here at the University of Washington, Wraparound Evaluation and Research team that includes Philip Benjamin, Alia Osman, Marianne Kellogg, John and myself, as well as many others, Mike Pullman, Jesse Suter. speaking of Jesse, my good friend and colleague Jesse Suter from the University of Vermont and I conducted a meta-analysis of wraparound outcome studies. The publication year was 2009, but frankly, we started this work as probably at like 2007. So it's been a good 13 years since we last conducted a meta-analysis. And the reason that we did it then as now, and the reason we continually update summaries of the wraparound evidence base and reviews of literature is that there's a lot of stakes. The stakes are high for outcomes of psychosocial interventions and strategies like wraparound or different kinds of psychosocial treatments. They wind up being evaluated by states, by managed care organizations, by individual provider organizations, and even individual practitioners about whether or not this is something that they want to refer kids and families to, whether they want to fund it, and so forth. The most recent example being the Family First Prevention Services Act that is relevant to child welfare. It requires, as many other kinds of initiatives do, evidence for the outcomes of any kind of strategy or treatment before it can be something that will be paid for, in this case under Title IV funds. So the stakes are high, and as such, we're trying to always keep the outcomes research base produce these kinds of summaries. More recently, in 2017, my colleague Jennifer Schroeder-Coldiron from our team did a comprehensive review of wraparound care coordination that was not a meta-analysis, but that did glean some of the lessons learned and findings. Next slide. So what have we learned up till now? We learned in the meta-analysis that we did in 2009, or that was published in 2009, that wraparound has significant small to medium-sized effects across multiple outcomes, with living environment and keeping kids in homes and communities being the largest effect size, but with significant, though small to medium, effect sizes found across an array of outcomes. Next slide. Jennifer and my study found that in our meta-analysis of 2009, where we only found 7 controlled studies, we found 22 controlled studies that met criteria in the peer-reviewed literature. And we found that 15 of those 22 controlled studies found outcomes favoring the wraparound group over comparison groups, with, again, the same array of outcomes typically being found. The problem being that the rigor of some of these studies was perhaps not meeting criteria that many inventories out there or people who are making decisions would like to see, and also few studies assessed the quality of wraparound implementation. So even in 2017, our conclusion was that the outcomes research base is strong, but we still have a lot of work to do. And so with that, I'll hand it to John to talk about what we undertook most recently, which is a new formal wraparound meta-analysis. You're on mute, John.
All right.
There you go.
Technology. I'm also having trouble getting slides to advance. So technology and myself are not getting along today. There we go. Okay. So I'm going to start with some of the research questions that we wanted to answer. We had 4 basic questions. The first was very simple. How many new evaluations since that last review that Eric spoke about have been conducted? And then a sub-question, how many of those have used high-quality methods? And we would describe a high-quality method.
Not right now, baby. Okay.
As randomized controlled designs, quasi-experimental designs where we had an adequate comparison group. The big question that we were interested in answering with this project is what effects does wraparound have on select youth outcomes? And I'll talk more about those outcomes in a moment. And then we had a couple of kind of exploratory questions where we were curious if there were any publication biases in terms of effect sizes across peer-reviewed versus other types of publications, and also a little bit of a look at whether implementation fidelity varies, the effect sizes vary across levels of implementation fidelity. And a little bit of a spoiler alert on that, not many studies look at fidelity. So I'll present what we have, but it is very preliminary. Inclusion criteria. So what did we include in this study? I'm going to go through this very quickly. Obviously, the intervention had to meet the definition of wraparound. We needed relevant outcomes, and I'll talk about those in an upcoming slide. High-quality research designs, as I already talked about, we focused on experimental and quasi-experimental designs. These publications needed to be published since 1991, and we specifically focused on peer-reviewed journals, gray literature, so tech reports, those types of literature sources, and dissertations and master's theses. And our target population for this particular study were youth ages 3 to 21 who were experiencing social, emotional, behavioral difficulties and or functional impairment. Okay, big slide here. I'm going to just hit the high points given limited time. This is our basic flow. The main points I want to make here is we cast the net very wide. We started with 3,100 records that were identified. Many of them were duplicates. Many didn't even come close to meeting our criteria. We whittled that down to 287 full text reviews that we conducted, and then ultimately had 17 articles that actually met our criteria. 11 peer-reviewed, 4 dissertations, and 2 great literature reports. Actually, there's 3 dissertations and a master's thesis. Outcomes, I'm just going to talk about broad categories. The measures varied widely from widely validated indices to parent report, self-report. So a variety in terms of quality of measures. But the main outcome categories that we examined were mental health symptoms, mental health functioning, juvenile justice, school functioning, residential outcomes, and then we separately looked at costs. So we looked at this first set of outcomes together and then did a separate analysis for cost. So let me run into the results. The first finding, very simply, are there more outcome studies of Wraparound over time that met our criteria? And it's a resounding yes. Now, you might look at that 2009 study and say, hey, I know there were more than 3 studies in that. What I did here, so we're comparing apples to apples, is that I applied the same criteria that we used for this current review and kind of went back to which articles from our previous reviews would have met those same criteria. So these are only peer-reviewed publications that focused on behavioral outcomes. And you see we went from 3 to 7 to 10 with about an equal mix of randomized control designs and quasi-experimental designs. So in short, there is an increase, has been an increase over time. This next slide is really our main research question. It provides the forest plot that shows the different effect sizes across these studies. This particular slide looks at the combined outcomes. So these are the effect sizes that are basically weighted averages across these different studies. We used Hedges G as our effect size measure, which is very similar to Cohen's D, interpreted the same way. It's just a little less reactive to small sample sizes. And when we're doing looking at so many different studies of different sample sizes, Hedges G provides a slightly more conservative estimate. I'm going to highlight the main number with all these numbers on this slide. This is the main one that we're interested in, 0.277. So this is our overall effect size across the aggregate, all of the outcomes that we were interested in, minus costs. Now, keep in mind, this is a relatively small effect size, but this is looking at the effects of Wraparound relative to treatment as usual, not a no treatment control group. Okay, so we're saying for youth that are in Wraparound are seeing a small effect above and beyond what they would get in terms of compared to other services they would have otherwise received. From here, we dug deeper and looked at specific outcomes separately, and you can see we have a wide variation ranging from a small effect size for juvenile justice, 5 studies looked at juvenile justice, up to a medium size for residential outcomes at 0.413. That's not really surprising. So what we see here is that residential outcomes, which one of our primary goals with Wraparound is to maintain youth in their families and their community settings, we do see larger effects there, with the other outcomes falling in between in that kind of small to medium range. When we look at these effect sizes, 0.2 would be considered small. As we start to get towards 0.5, we're considering it moderate. 0.8 would be considered a large effect size. So you can see we're really in that kind of small to moderate range for most of these outcomes. Okay, these couple of slides I'm going to go over fairly quickly because of time constraints. This is where we dug in deep to look for publication biases. I'm just going to present right now on this overall average, this bottom row here. You do see a small difference across peer-reviewed versus gray literature reports with a larger effect size for peer-reviewed, as compared to the gray literature, suggests that those with larger effect sizes are more likely to appear in published peer-reviewed literature. It's small, but it is something to keep in mind. Our next kind of subgroup analysis was looking at fidelity. Now, this was an analysis I was really excited to conduct, but we really don't have the data to make really large conclusions at this point in time. Only 3 studies looked at fidelity and found that that there was I would say, moderate levels of fidelity in those particular studies. So we compared this back to the full sample because we didn't really have a good sample of low fidelity to compare it to. There are 2 other studies that found low fidelity, but they looked at different outcomes. So again, it's kind of comparing apples to oranges. So we compared it back to the full sample of studies and found a slightly increased effect size, a slightly larger effect size for the moderate fidelity sample compared to the full sample. Really, clearly, this is an area that we need to do more in terms of digging a little bit deeper, having hopefully, as the literature base grows, having additional studies that look at fidelity. Finally, we looked at costs. 3 studies looked at costs, and many more in the literature have examined costs, but 3 met our current criteria in terms of having an adequate comparison group and any other criteria that I set out before. What you see here is, again, a kind of falling between small to moderate effect size that's driven largely by a single study that had a large effect size and 2 that had smaller effect sizes. So what we can conclude here is that we have preliminary evidence that relative to treatment as usual, wraparound is slightly more cost, has slightly more lower costs, I should say. All right, jumping into some conclusions. I'd start with just some future directions in terms of where we can go with research. Obviously, we reviewed a lot of research, a lot of papers for this particular project. So we have some conclusions we can draw from that. What are some of the holes? Clearly, we need more research. The research base is growing, but we do need more studies with high-quality methods, specifically those that focus on implementation processes, including fidelity measures, so we can really drill down deep and look at those differences across lower versus higher levels of fidelity. We could use more consistency in some of our measures. Sometimes we're comparing apples to oranges here in terms of the way that these outcomes are measured. And finally, it'd be helpful to have future studies start to look at how wraparound works for various subgroups, whether it's different ages, racial, ethnic groups, and so on. In terms of general conclusions, so if you tuned out a little bit, you can tune back in here, you get the full presentation, 4 simple bullet points. Most of the studies that we reviewed demonstrate more positive effects for wraparound relative to treatment as usual. We saw small to moderate effects across these multiple types of outcomes, and that came along with lower costs. So we're seeing small to moderate outcomes relative to treatment as usual at lower costs, which is very encouraging. The effect sizes were larger among peer-reviewed studies, and we have preliminary evidence that the higher fidelity implementations have slightly higher effect sizes, but we would need more data to really make conclusive statements there. So I'm going to hand it back to Eric to sum up in our implication slide.
Yeah, thank you, John. Well done. A note that I believe Janet might have said this, but if you have questions about this or any of the other presentations, please put it into the chat box and it should come to the presenters, and Janet is going to synthesize those questions. And for the last half hour of our time today, between noon Pacific and 12:30 Pacific, we'll address those questions. So real quick around this meta-analysis, we're really pleased to have conducted this and completed this. It also provides us with an extraordinary database of all of the studies that meet criteria for folks who want to, be able to dig deeper around juvenile justice outcomes specifically, cost outcomes specifically. We have the data at hand now to answer those questions. Overall, as John said, it confirms that under real-world conditions, because every one of these studies was conducted in the real world, none of these were pure efficacy studies where we were kind of controlling who was getting into wraparound versus the comparison group, where obviously there was very few studies where fidelity was really locked down. So, that's a weakness to some extent because we don't necessarily know what the full potential of wraparound to achieve positive outcomes is in the absence of studies that clearly are achieving high fidelity wraparound. The flip side of that is that we know that these data represent the kinds of effects that even under moderate to low fidelity implementation, you're likely to get if you do convene teams coordinated by a wraparound care coordinator to try to bring kids and families a more systematic and coordinated effort around receiving services and supports. So there's a positive there. It also confirms a theory of change of wraparound, that residential outcomes were a larger effect. We need to ask how we can get better clinical outcomes and functioning and symptom outcomes, but it does kind of really confirm that theory of change, that it's largely about doing whatever it takes to keep a child in home and community, and that is probably what's yielding the greater effect for residential and cost outcomes. So as I said at the beginning, this should aid federal, state, and managed care and other decision makers around reviewing the evidence. We have put that guidance out there around, for example, the specific need of the Children's Bureau to have evidence being presented by states to put wraparound, just like any other treatment, into their state plans. But these data are now available for folks to kind of make that case or evaluate the strength of the evidence themselves. And we're pleased to be able to have done that. So with that, I'm going to hand it now to our team from Connecticut, who are really going to give us, it's a great segue to their presentation, which is specifically about costs and the nature of services received by kids enrolled in a statewide wraparound program. So with that, I'm going to hand over the presentation to them.
Hello, everyone. Hope you can hear me. I'm trying to share my screen. Oh. Sorry, it happened just before the boom. There we go. So I hope you can all hear me. And today you're going to be talking about the cost-saving analysis of Connecticut statewide care coordination. I'm Chris Noam. I'm the health research scientist at Beacon Health Options. And behind me is a gigantic team of great researchers. Chris Borey is the Assistant Vice President of Advanced Analytics and Data Visualization. Robert Plant, who is the Senior Vice President of Advanced Analytics and Innovation. Gabrielle Hall, who is the Assistant Vice President of Child and Family Services. And Tim Marshall, who is the Director of Community-Based Mental Health Services at the Department of Children and Families. Today, I will be talking a little bit, I will go over the background of Connecticut care coordination as well as Beacon, and I will go into the methods that we used for this study, and then I will discuss, of course, the results and the limitation and the conclusions. There we go. Beacon Health Options is an integral part of Connecticut Behavioral Health Partnership, which is a partnership between the Department of Social Services, the Department of Children and Families, and the Department of Mental Health and Addiction Services. Beacon is the Administrative Service Administration in Connecticut, and it's the only administrative service administration that we have in our state. Our role in this partnership is as the Behavioral Health Service Administration, and we are focusing on organizing and integrating clinical management processes across payer streams, supporting access to community services, and promoting practice improvements of our providers, and assuring the delivery of quality services. And we want to prevent unnecessary institutional care of our members. We have a fee-for-service behavioral health carve-out system, which means that our state pays providers directly and to cover services, and we do not have a system of managed care. Also, our state, the fact that it carves out in behavioral health is pretty unique as well. Care coordination has been in Connecticut for about 20 years, and there are currently 10 providers serving 169 towns and cities. Care coordinators collect large amounts of data, which they put in a special system that is operated by DCF. We have a strong, there currently are being served about 1,100 families every year in care coordination. And usually families stay in the program for about 6 months. The program is targeted towards youth with serious and emotional behavioral difficulties and their families, and that are currently not involved in the protective services or in the juvenile justice system. We are trying to, the program is geared towards trying to avoid youth from being removed from their families or their communities. In this analysis, in this presentation I'll be giving today, we will be talking a little bit about the methods that we took, as well as the outcomes. Like I said before, as the only administrative service administration of Connecticut, we are able to have access to all of Medicaid data in the state, which is pretty unique. And we have a collaboration with our state partners, which allows us to bring these data sets together. We use the fuzzy match approach, which I will be talking about more shortly, and as well as the inclusion and exclusion criteria that we use to come to our final sample. And then we will, of course, look at the outcomes of this data, focusing on service utilization in higher levels of care, as well as the expenditures, reductions, and the cost savings. So to bring two data sets together, on the one hand, the state data set, and on the other hand, the Beacon Medicaid data, we use the fuzzy match approach. We started with a list of episodes of members that were served between September 2015 and October 2018, and we try to match them to the data, and we match them to the data from the Department of Children and Families. We looked at four main indicators, and a fuzzy set means that you look at decreasing levels of stringency on which the two data sets should match. So we looked at Medicaid data, and we looked at Medicaid ID number, first name and last name, as well as date of birth. With every step, the ranks became the matching criteria became a little bit less stringent. So if you see, for example, in the first rank, the first step, we wanted to have an exact match of Medicaid ID number, last name, first name, and date of birth. In the second step, we did not anymore needed an exact matching of Medicaid ID. And in the 2.5 match, we needed an exact match on Medicaid ID and not of date of birth, which allowed us for misspellings of first name or last name. The later ranks included a Soundex match, which means that we could match people together that had names that sounded the same, but were not exactly the same spelled. For example, names like Elizabeth, if it's spelled with an S or with a Z, or Neil, which can be written with an IE or EI or with an EA. Next slide. So we also looked at several of the episodes that we focused on were members that had a 60-month pre-period, and then a during period in which they were enrolled in care coordination, and a post period, which was also 6 months. We included only members that had at least one paid claim for their higher levels of care for the services in either the pre-period or in the post period. We included only people that had a continuous eligibility to Medicaid. And we include, when people had more than one episode, we included only those members of their longest episode that they were enrolled. Our final sample included over 1,600 members. To examine the Medicaid behavioral health utilization, we looked at the pre-period, the 6 months before they started care coordination, and the post-period, the 6 months that they continued, had the 6 months after they were discharged from care coordination. We categorized services by higher and lower levels of care, and we looked at as well as the specific levels of care. We also looked at differences between key demographics, such as race and gender, but we did not include those analyses here due to the lack of time. We also looked at specific diagnostic categories and whether there was a difference in members meeting treatment goals or not meeting treatment goals. So these are the youth that we served. We serve, as you can see here, most of the youth and families met their treatment goals. There were 2/3 of the members were male, identified as male, and the vast majority were in English-speaking households. We see that 1/3 of the members identified as Hispanic, a quarter did not identify their race or ethnicity, and about almost a quarter identified as Black, and about 1/6 as white, and about 1/6 identified as Black. We see that indeed that 2/3 of the youth did not identify as Hispanic. So let's look at the results, which is of course the most interesting and matches really well with the previous presentation that did not look at the cost analysis. So we see here, if you see the two top bars, you see this is where we grouped the levels of care to higher and lower, and the services that were provided within those higher and lower levels of care. And we see there were far fewer members that were served in the higher levels of care than there were served in the lower levels of care. We see that both the higher level of care and the lower level of care participation decreased between the pre-period and the post-period. Members that utilized a higher level of care service reduced with 36%, and the members utilizing a lower level of care reduced with 8%. There are significant differences between the members being served in the lower level of care to those being served in the higher level of care. And the graph below it, you can see that we broke it down as well by specific services, and we see that the biggest decrease was in the number of members served under ED visits, which is emergency department visits, in non-behavioral health. And we saw also that there was a big reduction in inpatient psychiatric acute care. For the lower levels of care, we saw the biggest reduction in outpatient behavioral health services, which can be questioned if that's a good thing, because perhaps we want youth to continue using outpatient services. We saw that the number of youth attending school-based health services increased, as well as autism services. The next slide looks at the total expenditures and the extent to which these reduced. We see also here that the higher levels of care and the lower levels of care both reduced between the pre-period and the post-period. Here, the gap between higher and lower levels of care is a little bit smaller, but that's because higher levels of care tend to be more expensive. We saw that in total, about $1.8 million were spent less during the post-period for the higher levels of care, and for the lower levels of care, we saw that this was a difference of about $1.1 million. The biggest reduction in expenditures was for inpatient psychiatric acute services and for PRTF services. When we look at the lower high levels of care, we see that there was a big reduction in ICAP services, as well as for the outpatient behavioral health services. We see there was an increase in services for autism, expenditures for autism, as well as expenditures for school-based health services, which is probably because we saw in the previous slide that more members were served in those fields. So this is a very short overview of the impact that care coordination or wraparound services can have on the members attending lower and higher levels of care before and after being enrolled in care coordination, and as well as the expenditures associated with it. And a few limitations of this study were that we had state-operated inpatient hospitalization and psychiatric residential treatment facilities claims data was excluded from this data because there was a coding anomaly in 2016, and which would have skewed the data. We also decided to look at a 6-month pre-period and a 6-month post-period, and perhaps this is a too short or too long of a time to be looking at for cost savings. This data does show, by bringing 2 data sets together of the state as well and match it with our Medicaid data, does show us that it can be very beneficial to bring the 2 data sets together. It shows that we had a decrease in spending, and it shows a decrease in the total of number of youth utilizing these services. So it does, I think it really shows how the partnership between the state and an ASO can be very beneficial in understanding some of the wraparound questions further. I think that's it. Right, I don't know if the next presenter wants to share their slide or their.
Thank you so much, Chris. Next up, we've got Tony Bonadio from University of Maryland, and I'll vamp for him while he's getting his slides up for the group. But fantastic presentation from our Connecticut colleagues, and it's just extraordinarily impressive the degree to which you were able to make use of those Medicaid data. And I think, you know, the findings are interesting, but the methods is something that other states would benefit from learning from, as well as the outcomes. So thank you very much for that. Looks like Tony is up, and so I'll hand it over to him.
Great. Thanks, Eric. Hi, everyone. As Eric mentioned, my name is Tony Bonadio. I'm at the Institute for Innovation and Implementation at the University of Maryland School of Social Work. And today I'm going to be talking about some of the early attempts to measure implementation of Wraparound and how that relates to fidelity and then ultimately to youth level outcomes. A lot of this work has been supported by my colleague, Sumaya El-Sawaifi, and I want to recognize her efforts, but also I work with a lot of the National Wraparound Implementation Centers, NWICS coaches, and they have also supported a lot of this work in data collection, so I want to recognize them as well for all the amazing work that they do and their support for this evaluation pieces that we will be sharing with you today. So there we go. Okay. So again, just a quick overview. I'm going to present the implementation framework that was kind of driving some of these questions and that how we will kind of frame the use of these implementation measures and how they relate kind of downstream to fidelity and outcomes. I'm going to spend a little bit of time going through the actual measures just so people can be familiar with what they actually look like and how they're used in coaching particularly, but also, you know, from the evaluation lens. And then I'm going to share some very preliminary findings. This is the first time we've really looked at these data, these implementation level data, the organizational level data in connection with fidelity and outcomes. So I just want to be clear that these are very preliminary, but hopefully they will drive more questions and be able to kind of help us take the next step in understanding how those implementation factors really impact the services that are delivered and ultimately, you know, the services that we can provide for youth and families. And then I'll give some conclusions and next steps. Oops, too many. Okay, so to frame this discussion of implementation factors, we're using this implementation framework, which is CFIR, for the Consolidated Framework for Implementation Research. And CFIR really is more of a framework than kind of a causal theory or model, but it really just kind of outlines and classifies different facilitators and barriers at the organizational and system level that can actually impact the delivery of an evidence-based intervention and then ultimately outcomes. So people may be familiar with this model, but you know, it breaks it down. It breaks implementation factors into these 5 categories. So the outer settings are really focused on the needs of the general population, external policies and funding streams that are available, those types of things that are outside the control of an organization, but that impact what and how an organization can deliver services to youth and families. You then have inner settings, which really look at the inner settings of an organization. So that might be the structural characteristics of an organization, the culture and climate of an organization, their readiness for change, organizational leadership and how they view change and the intervention that may be implemented, also the resources that are available to both staff and leadership of an organization. intervention characteristics in the upper left there is exactly what it sounds like. It's the characteristics of the intervention that's being implemented. So that's about cost and the ability to maybe test it and then scale an intervention. So those all kind of fall under that category. The process of implementation is really factors that are involved in planning, engaging the community, identifying champions of an intervention, those types of factors. And then individual and team characteristics are focused on staff and management of an organization and their readiness to change, their training and skills, and those types of things that are specific to individuals on a team. So to apply this, when we think about this in terms of wraparound, we really are thinking about how staff and supervision can support the implementation of wraparound, as well as how leadership can support that implementation. Studies have shown that those factors do impact how a service is delivered and ultimately outcomes, not just in wraparound, but in other evidence-based interventions. I don't know why that changed. As John had mentioned in the first presentation, there is some evidence that fidelity impacts outcomes. So, there is as little of research that John spoke about of having fidelity tested in those studies. I would say there's probably even less studies that include information around implementation factors. So when we think about where kind of folks are generally, a lot of organizations are good at tracking outcomes. That's something that they may have been doing for years now. More and more fidelity measurement is becoming part of that through the efforts of the Wraparound Evaluation and Research Team, Eric's group, developing tools for that. But really there haven't been practical tools for the measurement of implementation factors. And so recently the WISP was developed, which is the Wraparound Implementation and Standards for Programs. And this is a tool that's specifically designed for practical assessment of those implementation level factors and organizational level factors. So the WISP is designed to be completed at the organizational level, so it's not assessing individual care coordinators or individual youth and families, but it's really assessing how an organization is doing on several of these different areas of implementation. And so it's broken up into 3 phases, so pre-implementation, implementation, and sustainability, and then under each of those phases are these subscales. And so each of these you can see that they're similar across each phase, but the items within that make up these subscales actually vary at each phase based on what would be the expectation to be happening in an organization during that stage of implementation. And so the WISPs are typically collected by, well, currently for our project, by NWIC national coaches in collaboration with organizational leadership and management. So kind of sitting down on a regular time frame, whether that's 3 months or 6 months, going through the measure and scoring the items in each of these different categories. And I'll show you what those items look like in a second. And the idea is that by taking that time to assess and score how implementation is going, coaches can support organizations, and organizations can understand where to dedicate time and resources to improve their implementation. So if we look at, this is the actual items, some of the actual items from the WISP. So in the far left column where it says category, you're seeing these are those subgroups, or those subscales, so organization versus, and then the bottom one shows the wraparound care coordination subscale. And then each color represents a different, or each column represents a different phase. So you can see how the items vary between each phase. And then each of these is scored on a 0, 1, or 2, depending if it's fully met, partially met, or not met. And so those are scored, hopefully at multiple time points again, and is used as a coaching tool. So that's the WISP, and that provides that the data around organizational level factors, and this couples with then the DART, which is part of the WAFIS system, so for assessing fidelity. And so the DART is the Wraparound Document Assessment and Review tool. And folks may be familiar with the WIFI Easy or the TOM. The DART is part of that package of fidelity measures. Obviously, the difference is that it's used primarily through documentation review or exclusively as documentation review. So a trained coder would review documentation of a provider organization, and they would assess to see if the indicators of wraparound practice adherence are being met based on the documentation available. And so it is a very thorough review of documentation and can vary from site to site. There's no set document. There's set information that needs to be in those documents, but the way that those documents are organized is not necessarily, it can vary from organization to organization. The DART assesses 6 areas that are listed in that box. The key elements, which is the biggest area that is assessed, is actually broken down into some subgroups or some subcategories there to look at different key elements of wraparound and to assess whether those are being met. And so they are assessed through reviewing plans of care, through critical incidents documentation, some outcome reporting. So that is how the DART is collected, and then it provides scores for each of these. Again, the DART can be used by coaches to help in workforce development and planning for trainings for staff. So here's the actual example of the DART around wraparound key elements. Again, they're scored on a 2 or 0, 1, 2 scale. Some items are yes, no, so they'll just be yes or no, but most items are 0, 1, 2. And so conceptually, the idea is if we go back to the CFIR model, if organizations have the implementation structures in place to support staff and supervisors, then they would have higher levels of fidelity, which would lead to better outcomes. And so that kind of led us to want to look at a few things in across these measures. So given that this was our first time using the WISP, we were just very curious as to what the variation in scores look like across a statewide system using Wraparound. So that there's lots of provider organizations, and WISP were collected with each organization. So we were just curious to see how those scores vary across organization. The second question was, what was the relationship between those program level factors identified in the WISP, in wraparound fidelity, and finally, how do those program level factors impact outcomes? So we had DARTs and CANs, which we use for outcomes, for 355 youth and families who were receiving wraparound from 22 wraparound provider organizations across the statewide system. As I mentioned, we use the WISP, the DART, and for outcomes, we use the CANs, which is a common measure that we will hear more about shortly. And then we looked at those organizations that were classified as high implementers, so they had scores above the midway point on the WISP scale versus those who were below that midway point on the WISP scale. So for the first question of variation in WISP scores, you can see that there is a lot of variation both across and within organizations. So some organizations were all scored high across all scales, like you can see in that green box there, and then other organizations scored high on some of those subscales and not others. So looking specifically at organization, supervision, and care coordination, you can see the amount of variation both across and within organizations. Overall, when we look across the state, the wraparound provider organizations scored the highest on the organization and supervision subscales and scored the lowest on the care coordination subscale. So care coordination subscale really looked at training and support of care coordinators, as well as their skill attainment as rated by the COMMENT, another measure of wraparound skill for care coordinators. When we look to see how these scores impacted the fidelity delivered by those organizations, we see that those organizations that were higher implementers in the care coordination factor had higher levels of fidelity than those who were lower. However, that was not true when we looked at high and low implementers for organization and supervision. There was no significant difference in those scores, but it did not show that higher implementation led to more or higher fidelity scores. So then we looked at what was that impact then on outcomes, and so we ran a regression model in which we regressed CAN scores, final CAN scores, on those organizational factors as well as on fidelity scores, controlling for CANs, all of CAN scores across all time points. And what we found was that fidelity actually predicted fewer needs in CANs at discharge, I guess we could call that. But the organizational factors did not predict less needs at discharge. In fact, organization and care coordination subscales actually predicted higher or more needs identified at discharge. And we'll talk about why that it seems counterintuitive, but there may be some explanation for that. So in summary, there was significant variation in these organizational factors across a statewide system of care using wraparound. Wraparound providers who have well-trained and supported staff had higher fidelity scores. And program level factors did not predict improvement in outcomes, and in fact, they showed that those outcomes may be a bit higher as rated by the CANs. So this obviously was counter to what we predicted in that association, and given the variation within organizations across those implementation factors, there seems to be some more complex interactions that may explain why there's so much variation, as well as why the predictions and outcomes were counterintuitive. The other one hypothesis would be that care coordinators who are well trained and well supported may be better at identifying needs on a CANs than those who are not. And so that would lead to more needs across all time points because they're better in that discovery, gathering the family story, and that assessment process, a collaborative assessment process. However, well-supported care coordinators did show improved fidelity, and that fidelity did predict youth level outcomes. So for future research, for kind of next steps, there needs to be a more nuanced approach to how these are both analyzed and understood. There is some interactions, and not all of these factors may fall within that intersetting feature. You know, some of these may be dictated by the larger system, and so understanding kind of that outer setting and how that impacts and maybe interacts with those intersetting factors could also impact outcomes. We need to look at implementation over time. As implementation improves, would we expect then to see maybe more changes in both fidelity and outcomes? And then, yeah, finally, there's interaction effects. So that's all from me.
Thanks very much, Tony.
Eric?
Just like, yeah, can you all hear me?
Yep.
Just like with conference presentations in person, we always have our best intentions of having, because I need to do some share content here. If anyone is not seeing the presentation, please let me know. I think we've got that done. Does that look okay? If not, let me know. But yeah, we've, whenever we do presentations in Tampa, the joke is always that you say you're going to save all this time for questions, and then you actually don't. But even though we're a little over, I think we'll have plenty of time. We've gotten a ton of great questions, and we will have at least 20 minutes at the end of this hour and a half to dig into them. So please hang in there till half past the hour if you can. One thing to talk about with respect to Tony's presentation, which was, we're really excited to have Tony doing this work, even though as he kind of described, some of the findings are a little bit challenging to interpret. Others make sense as hypothesized about the relationship between at least some types of fidelity and outcomes. But there are all sorts of challenges in interpreting the data when you have so many complex interactions. The main point I think that we're really excited about is that the National Wraparound Implementation Center collects all those data to try to keep our sites on track in our states we're working with. And now we're really beginning to get to this point where we have enough data across all of those pieces of the implementation framework to begin to explore some of these. And a little pitch, which is that on June 30th, we will be doing another webinar that drills down to lessons learned from implementation research wraparound, largely from all of these different data that are collected as part of the National Wraparound Implementation Center's efforts to train and coach and provide TA out there in our systems of care. So be on the lookout for an announcement and a link to register on June 30th. Okay, so last presentation is really one by our very valued colleague, Spencer Hensley, who has moved on from the Wraparound Evaluation and Research team to work in the public health field. And he cannot be here to present his own master's thesis findings because he is now a lead evaluator at King County Public Health. And needless to say, in the era of the COVID pandemic, he is out in the field doing a ton of different things that he's needed to do for his new job. So we're sad to not have Spencer present these data himself, but I am happy to do it. And it really does kind of dovetail with Tony's presentation in that it unpacks some of the issues about use of the Child and Adolescent Needs and Strengths, or CANS tool, as an outcomes measure for wraparound care coordination. What the study did, as you'll see, is compare CANS data for 122 wraparound enrolled youth to a matched sample of 122 youth served by other service modalities in the same agency, all kids with serious and complex needs. And our Spencer's research focused on asking, using that quasi-experimental matched sample design, understand impacts of wraparound on youth functioning as assessed by the CANS, which was used by this large provider agency for all of its wraparound enrolled youth. And as I said, we also wanted to ask how best to apply the CANS as an outcomes measure, because there was some interesting things that were surfaced really clearly about using the CANS in this study. So I think that you all know the backstory. We should try to benefit from our data that we're collecting at every turn. A lot of places collect fidelity and outcomes data and never really use that to answer local questions, let alone do research. And so we need to do this as often as we can, both for informing our local implementation efforts as well as for the national field. For the CANs, there are a number of considerations about how to use the data if you're going to use it to try to evaluate impact. So let's talk about all of those needs here. The CANs assessment, most folks probably know about it. It really prioritizes communication of actionable information rather than taking a traditional kind of psychometric approach. It covers a wide domain of youth needs and typically has a whole lot of items. The version in this agency was 68 items across 7 domains. And strengths and needs scored from 0 to 3, where 3 would be the highest level of need, and 2 and 3, scores of 2 and 3 indicate actionable needs. So here's some examples of CAN's domains and items. The domains in this agency were behavioral and emotional needs, life functioning, risk behaviors, cultural factors, caregiver resources and needs, child strengths, and adverse childhood experiences. And there are some examples of the items for each of those domains. Apologies to our interpreters for me talking so fast. So our research questions are: what changes in CAN's needs were found for wraparound versus the matched comparison group at 6 months? Are more actionable needs resolved for youth in wraparound? And as we see with the CANs, and as Tony referenced, it could very well be that different types of service modalities are better attuned to discovering new needs. And so this makes interpretation of CAN's data challenging, because if you are uncovering new needs as opposed to having kind of a much less nuanced measure that just kind of asks about, for example, overall functioning, you may have a confound when you're trying to use it as an outcomes measure. So you have to look at it in some unique ways. And so we were looking at both actionable needs resolved as well as new needs discovered. So the method, which I don't have time to get into in great detail, but Spencer was able to take a large agency database of outcomes measures or outcomes data for many hundreds of youth, and found that for wraparound, there were 129 youth in this agency that completed both a baseline and follow-up CANs, as well as over 1,000 kids who received other services. And so with that large comparison group, he was able to successfully match 122 of those 129 wraparound enrolled kids to a comparison youth, and he was able to analyze 122 to a matched group of 122 kids with similar demographic characteristics at baseline, which is what you're seeking if you want to use a quasi-experimental kind of design. And so this just kind of tells the story of the success in using propensity scores to identify a matched comparison group that Spencer was able to achieve. The blue dots there on the left of the screen represent the difference between the wraparound and comparison group after doing propensity score matching. And you can see that all the differences across all of these different demographic and risk factors of a Cohen's D referencing effects of very small to negligible effect size in terms of the differences of these groups in these particular variables with respect to these particular variables at baseline. So there was good confidence that statistically, at least on these variables, the similar. And so then Spencer used general linear regressions to examine the average change in actionable needs. So basically asking, if you just calculate a mean score of actionable needs at baseline in 6 months, what were the differences between the two groups? But then drilling down, given the unique nature of the CANs, what was the number of actionable needs at baseline that were resolved at 6 months, as well as the number of actionable needs that were discovered? And how did all those variables differ between the two groups? So the results were really interesting. We found that that both groups saw a decrease in the average number of actionable needs, those that scored a 2 or a 3 on the CANs, from baseline to 6 months, with the wraparound group showing an overall greater reduction in needs of 1.46 versus 1.11. However, there was not a significant difference between the two groups. Both groups showed a significant decrease, but not a differential decrease. The differential decrease was not significant by group. However, a different story is found if you just look at the number of resolved needs at 6 months. So, you know, it's that real painful situation where the totally arbitrary setting of a p-value of 0.05 was not quite met, but there was a reasonably sized effect size between the two groups of, I think, about 0.2. Almost met that standard. You could say that it was a marginally significant finding, but the bottom line is that the wraparound group showed an average number of resolved needs from baseline to 6 months of 4.63 compared to 3.5 for the non-wraparound group. And some of the domains were particularly larger than others, like child strengths. More child strengths were improved over time than for the non-wraparound group. And again, we're pushing against significance there, but not quite. The other piece of the story is that wraparound youth also had a larger number of discovered needs at 6 months. So this is going to mask the degree to which using the average number of actionable needs from baseline to follow-up is actually a metric that's useful in wraparound. If you also see that wraparound discovers more needs than non-wraparound based services, then you're going to have to find other ways to use the CANs than just the typical mean score at baseline and follow-up. And so here again, the significance level, except for cultural factors, again, which kind of aligns with the wraparound theory of change, was not significant, but you do see this effect of, you know, nearly one full need greater discovered for wraparound kids matched comparison group. So what does it all mean? Approximately one more need was resolved in the wraparound group, and it's a borderline significant, small, but seemingly meaningful effect size. And although again, not even quite borderline significant, but perhaps meaningful, more needs are discovered at 6-month follow-up for the wraparound group. And this may indicate, as Tony also referenced, wraparound's ability to engender trust in families, to really be digging deeper than typical service modalities can to uncover new needs that require attention. Clearly, a lot of limitations here, not an experimental study, and anything that wasn't in that list of variables that was controlled for statistically might have been a difference. Type of insurance, specific mental health diagnoses, the mix of youth in terms of which systems they were involved with might have been different. None of those were controlled for or used to match the groups. Parental preference for type of care could be another confounding factor. Could be that the kids in the other group did not choose, or their parents did not choose wraparound for a reason that also led to differences between the two groups. We just don't know, and that's what happens with quasi-experimental studies, even when you use propensity score matching. In addition, the comparison group receives services from the same agency, and that could vary greatly in intensity. We don't really know what we're comparing the wraparound group to exactly. We also, as we've seen, and but the wraparound training and regular supervision. And finally, we also only looked at change up to 6 months. But the implications are still there, and one of the big ones is just to highlight that the ways you score and interpret the CANs really makes a difference. So in addition to the ways that Spencer did with looking at needs resolved and needs discovered, in talking with Kate Cordell, who's a real expert on this stuff, you can compare groups on change in ever actionable needs, which I think is the way Tony was working with his CANs data, groups just on the needs that were targeted for treatment, which might make for the most meaningful and sensitive approach. Or compare groups on the number of items where the score decreased by at least 1, which also could be more sensitive than looking at average scores. Another thing is that an issue with the CANs is using an alternative baseline assessment point than before entry to services. You know, the tight turnaround time, and we're trying to get kids into services, and there's often requirements that you do a CANs at baseline or at referral. And it may be that this means that we don't really know what the family's needs are fully, but yet that represents our baseline assessment, which could be a problem if you're really trying to use the CANs as an outcome measure. So takeaways: this contributes to the effectiveness research, such as that John presented in our meta-analysis, and it really does highlight the opportunity that propensity score matching could provide to big agencies or states or whatever to try and unpack what some of the findings are from their local implementation efforts. And it demonstrates the dynamics around using the CANs. There's a wealth of options for evaluating CANs change, and we need to keep examining the options. So here's my contact information. I have gotten a few comments directly to me about questions that they would like, folks would like follow up on, and I encourage you to email me as well as to check out my Twitter feed. And again, we got to really thank Spencer Hensley for being willing to share these to the field even in his absence. So with that, I'm going to stop. Well, maybe I'll keep my video up and let Janet put the video back up and put some questions out there to the presenters that she's gotten.
Sure, thanks, Eric. So going back to the very beginning, there were a couple questions for John. I think this was covered, but probably needs a clarification. Have the comparisons made between wraparound in the general sense and high fidelity wraparound, I guess, been made? WRAP has become commonplace, and it seems data that differentiate the two are not determined clearly.
All right, good question. So a couple of things on that. First, when we went through our criteria for what was included or not, we only included those that met the criteria for wraparound. That was a pretty extensive list in terms of the basic principles of wraparound. So we're pretty clear that all studies that were included met the basic definition of quote-unquote wraparound. There are all kinds of interesting other completely non-wraparound, wraparound porches, these and those kinds of things. But even within the general field of wraparound, we tried to make sure we got those that were relatively high fidelity from what we could tell. Now that said, in the presentation itself, I talked a little bit about how not many studies have specifically measured wraparound fidelity through the various indices that we have. But we did see some subtle differences, and that's where we just need more growth in the field to really look at those differences across those that are really at that higher level of fidelity versus a lower level of fidelity. We just didn't have enough studies to truly make that comparison yet. But we did see preliminary evidence that there's some differences in effect sizes across the two types of implementation, higher fidelity versus, for us, it was just the general body of literature. And over time, hopefully we can get a little bit more nuanced and look at the high versus low fidelity.
Yeah, a lot of work left to be done. Thank you.
And on a related note, for the meta-analysis study related to future directions, what plans, if any, do the authors have to continue to monitor the evidence base? I wonder how much research is out there that never makes its way into peer-reviewed outlets but may meet criteria. Would sites, for example, that enter data into WrapTrack be a good way to identify evaluations doing fidelity assessment? And could you assess each licensee's evaluation designs at the time the licenses are established to see if they are conducting high quality research?
Yes, it's a great question. I think folks need to mute because there's a bit of an echo, but I'll take this at the beginning and just say that, remember that we did look at, the first part of your question is, what about things that don't ever get to peer review? And we did look at the gray literature. So we made a call for reports from agencies, states, et cetera, to try and get those into the review. And we did find a few. So they were included, but it's a good point about generating more research. And we have, on occasion, kind of put calls out to the users of our fidelity tools around, do they have outcomes as well? And the challenge is that, you know, as we saw from Spencer's study, if you don't have some sophisticated ability to do propensity score matching and account for all the missingness that tends to happen out there, I mean, you saw that the data, there was a good loss of like 3/4 of all the folks who had a baseline CANS in both groups didn't have a 6-month CANS. And so, you know, when you start getting into all that missingness, it's really hard to make sense of what is usually outcomes measurement as usual. But it's a really good point. And just with respect to your great suggestion about looking at WRAP track or WAFIS tool users, that's the system that we currently have to enter fidelity data. We're moving to a new system that will allow every Wraparound Fidelity Assessment Sister user site to have a roster of all youth and just a few items that we're going to be able to use more consistently across the country for those who sign up, including all National Wraparound Implementation Center recipients of training and technical assistance. We're going to ask every single user to indeed put a couple of really critical outcomes into this database, including, most importantly, disposition, a reason for discharge. And so we can do analysis of what factors might influence this real bottom line outcome that every wraparound program should be tracking, and that will now be uploaded into our system, which is, did this youth and family discharge from wraparound because of successfully meeting needs versus some other reason, which we'll track, like placement in residential treatment, or disengagement, or family didn't want it anymore. And so we think that's going to be a real powerful way to get it, a piece of what you're suggesting. John, anything else to add?
No, I think that pretty much covers it. To answer the very first part of the question, yes, we do plan to continue to monitor the evidence base and updates. It seems that we're on a cycle of having these kinds of projects continue, because the evidence base is continuing to grow. And it is important to identify ways of getting in that gray literature, the non-published work as well. So good points.
Yeah, we will, as we have been for many years, periodically do these reviews, even if we don't do this extraordinarily intensive meta-analytic piece.
All right, moving on to Chris's presentation. Here is a question about why the increase in autism. I think that might have been the expenditures driven by a small number of kids, question mark. Also, any ideas about use of state-run hospitals since you couldn't access the data?
So I think indeed the increase in autism services expenditures is because they increased the number of members enrolled in those services increased. So that, of course, drove up the costs for them as well. As for the statewide, the state level services, I don't know exactly if those services have decreased as well. I think they have, but we were just not able to reliably look at those data because there was an issue with the claims data in 2016, and we didn't want to, therefore we excluded them from the analysis. Does that answer the question?
Well, if that doesn't,
I think the question might be, do you have, oh, I'm sorry. I think the question might have been, do you have any ideas about what might have happened? Because is that a lot of kids or a small number of kids? I mean, it could be a big factor in costs if it's missing, then, you know, how much of a factor do you think that might be in skewing your results?
So I'll let Chris Borey talk for that, because he was actually a part of the organization in 2016 while I was not. So maybe he has a better sense of what happened and how many kids we're actually talking about.
Yes, thanks, Chris. So for the autism services, our program, we started up as a Medicaid reimbursement program from autism services in 2015. And so we would expect to see an increase in expenditures over time as we started to expand the network of autism providers throughout the state. So that wasn't all too surprising given the context of the state and the autism services that we're expanding across the state. As for the state expenditures, there was a coding anomaly. One of the things that we were thinking that we could possibly do in the future is to look at those expenditures where the coding anomaly was not present. So in about a year or two, we could probably then include those numbers back in. In terms of N size, it's probably not very many people, many youth that are involved there, but we would be able to look at that at some point in the future.
Well, thank you. And now moving along to Tony. Can you speak to how the benchmark percentages within the WISP tool for a given item were determined? I think you might be on mute, Tony. We can't hear you.
Is that better?
Yes, good.
Yep.
Okay. Since the WISP is a relatively new instrument, there aren't currently national benchmarks that are provided. So for the results that I showed, I used a center split on the scale. So I split it at 50% for high and low implementers, primarily just so there was a consistent split across all three scales, showing the mean difference. You know, using a mean split across that would have meant that the benchmark for the care coordinators would have been significantly lower, since the overall mean for that was significantly lower. So there is no, but it was not a validated kind of benchmark that is used nationally.
Yeah, it makes me wonder, Tony, if the question is more about what represents high versus low, or a 1 versus 0 on each of those items. I'm not 100% sure what the question is, but that might be what they're getting at as well.
So Eric, more about how it's scored specifically to when coaches complete that, you know, are able to give a 0, 1, 2. That's a great question, and you know, I would say that coaches and/or would better be able to answer specifically how that determination is made. There is some, you know, within the tool itself, some of those items have specific cut points for items. You know, 100% of youth had a CFTM within, you know, the first month. So some of those items have that specific number to say like that was fully met or not. Other items, I think there's probably a bit more subjectivity in determining what's a 1 and what's a 2. And I don't want to, you know, the coaches who complete that with leadership would have a much better idea of how they do that scoring than I would.
Yeah, if that's the question, I think it's just important to note that there's a pretty detailed scoring rubric that the coaches use to evaluate each of those necessary conditions for wraparound at the organizational level.
Thank you. And I'd encourage anyone, if you feel we've misinterpreted or insufficiently answered your question, go ahead and type it back into the box, and we can get back to it if there's time. This, I think, is a more general question, although perhaps one for Eric. Any research done with wraparound transition indicators and cans?
Work done with wraparound transition indicators and cans. So I guess the question might be the association between CAN scores and readiness for transition, or it could be about use of CANs to aid transition at a kind of more team level decision. Not sure which. But on the first one, I think we're still kind of exploring the ability for us to kind of put different pieces of data together to ask questions, and that would be a reasonable one if we had the data. With respect to the second, I do think that there's a lot of folks who are trying to use CANs at a team level to inform decisions. We have an entire webinar just on that topic, and probably even more helpful than the webinar and easier to kind of access is an entire guidance document on using the CANs to support decisions at the team level and wraparound. And if you went to that, which should be easily found on the National Wraparound Initiative website, you would see a whole bunch of guidance about ways you should and shouldn't use the CANs if you want to incorporate it into as a decision support in wraparound and want to do it in a way that actually adheres to the principles of wraparound. The biggest one being that CANs should never drive a plan and CANs should never drive transition decisions. It can inform those decisions, but it's always got to be a team and family-driven approach as opposed to a data-driven approach exclusively.
Okay, and this is one of our last questions. There is a lot of quantitative data that gives a broad view. What is the place of qualitative research for depth in understanding wraparound processes and outcomes?
Such a great question. I think personally that we have, we found 206 studies, and that was like 4 years ago, in the peer-reviewed literature, and that doesn't even, as people have pointed out, account for all the technical reports and other sources of that we could go to find wraparound research. We always encourage that at a local decision-making level, qualitative data needs to be equally weighted, if not more weighted, and that adheres to the wraparound principle of family voice and choice, as well as being outcomes driven. So if you're not using those open-ended fields in your fidelity surveys, if you're not asking those questions in an open-ended fashion, as well as collecting these quantitative data, you're missing out on the richness of information that you might need to help guide your local wraparound initiative. So absolutely, it needs to be something that's done frequently and then matched up to decision information needs for decision making. At a research level, I think that you are spot on. We would benefit greatly from more rigorous qualitative or mixed methods studies that really unpack those things. There have been a number of them, and if you go to that review that I talked about that Jennifer Short-Coldiron is the first author on, you will see a summary of just how many studies were qualitative, and there's a good number of them. But I 100% agree that to get a full picture of the wraparound research base now and going forward, we should be relying on qualitative and mixed method studies as well. They could uncover a lot of the information that we need on some of the dynamics at all of those levels that Tony described in the implementation ecology. What were the factors that were barriers to getting to the necessary conditions at the system level or the program level? We have, data on that come from the stakeholders. What were the experiences of families? Again, got to collect that in your local evaluations. We could do more of it in research as well, or at least find those data and take advantage of them. Great question and comment.
Okay, so this last question comes out of the Q&A section, and this is a question for Chris, wondering about what the average number, I think this is team members at transition was for the families in your study, and if they had any breakdown for whether the numbers of formal versus informal supports on the team.
Okay. I'm not sure I understand the question about transitions.
I think it's just talking about kind of at the time when wraparound was well established or wrapping up. Do you have any information about who was on the wraparound teams?
This is Chris. I
Yes.
can answer that. We do have it in one of the data systems, but we did not pull it into this study.
Thank you.
Okay, thanks.
Chris, do you have any idea what the data said from the other data system?
There was a presentation that we did at Tampa last year with our colleagues at Yale, Joy Kaufman, that had a in-depth analysis at looking at the team composition as well. our other colleagues. I think it was last year in Tampa where they presented on that, and I think there was a subsequent publication on that as well on team composition. But we didn't look into that for this study.
All good. Thank you.
All right, well, I'm going to call this one our last question. Is there research on fidelity of wraparound when a family peer is assigned versus when one is not assigned? And I will just say from my personal experience, I am not aware of that. Eric, do you have a different idea?
Well, I think that it might be interesting to hear you. We're a little bit over time, but some people will hold on and we'll have this recorded. But you might talk about youth peer-to-peer support, Janet. In terms of family peer-to-peer support or parent peer-to-peer support, we did do a study that we presented at Tampa 6-7 years ago that took all of our wraparound fidelity index data and asked, are there higher scores for teams that identified presence of a peer support, a parent peer support worker? And we did find higher fidelity for the teams that, and this is across thousands of wraparound fidelity index interviews, did find higher fidelity for those teams that had parent peer-to-peer support. It wasn't a huge effect, but it was significant.
Interesting.
I haven't published that though.
And as far as with youth peer support, we haven't exactly looked at fidelity, but we have some evidence that speaks to the idea that youth peer support can result in greater engagement of older youth and young adults who are involved in wraparound. All right, well, I think this is a good time. We've reached our limit. I want to thank, excuse me, all the presenters particularly, and also, of course, everyone who took their time out from their day to tune in with us. As a number of you asked about the slides, we will be sending around an email, so when those are posted, you will know. And always a good idea to check the NWI website if you want to keep up with any further announcements about this and other wraparound topics and other webinars that we're having in the future. And if you just put NWI wraparound into your search engine, you will find that very easily. So with that, I think we're ready to close. Again, I hope the rest of you have a great rest of the day. Thanks.
Take care, everyone.